Okay, thank you very much, Saurabh. That was a good, honest review of that. So even Saurabh sometimes does stage surgery, so that plays into my side quite nicely. Okay, so I'm defending stage surgery. So just as a quick introduction, personally, I think this is probably the most complex area in knee surgery. The presentations are uncommon unless you work in a major trauma center where these are coming to you all the time, or in a country where there's a lot of polytrauma. You're not going to be seeing a lot of this. The injury combination is very heterogeneous, okay? So you can't say with evidence what to do in a particular situation because there's no evidence for it. The neurovascular considerations in this are massive. And then we need to divide multiligament knee injuries versus, as Sora pointed out, versus low energy, which is sporting injuries, and polytrauma and proper knee dislocations. They all result in multiligament damage, but they're not the same. The other considerations are access to allografts. How long is it going to take you to do 2-3 ligaments in a sitting? The length of surgery, the complexity of the reconstruction and skill level is important. Do you have access to proper rehab afterwards? And what is the evidence for all of this? So the key thing is know your injury pattern. So we've only got 5 minutes. So I'm not going to go through the whole thing around how you do this, but the key thing is know your pattern, and there's lots of ways to do all of that. Stress x-rays are helpful to guide you. MRI scans, 100%. Get those done, know what you're dealing with. And this is just a scan showing ACL, PCL, MCL, and injury to the lateral collateral, okay? So this is from the Leprard paper, and he's looked at only sports injuries and high-level sportsmen. And if you look at that box, the combination of injuries of ligaments, there's 1, 2, 3, 4, 5, 6, 7, 8, 9 plus different combinations of ligaments that you can have that you might want to reconstruct. And so that makes the whole situation much more complicated. What about this situation, right? Massive injury to the knee. You've got a vascular injury as well. Are you going to do this in a single stage? You're definitely not going to do that, okay? So the definitions are also important, and we touched on it. Early surgery, generally within 3 weeks. Delayed is more than 6 weeks. Single stage, is it early reconstruction or early repair of all the ligaments? And staged is early repair of the collaterals and delayed reconstruction of the cruciates. So what options do you have? The 3 options are repair everything in the beginning, and that has problems of its own because the intra-articular ligaments can't always be repaired adequately, and neither can the collateral sometimes. My preferred approach is stage surgery, where in the acute phase you do an open or augmented repair of the collaterals followed by a subsequent second stage reconstruction of the intra-articular ligaments. And the third option is wait, and do it all in one go. So this is the paper that Saurabh was referring to, which is single-stage multi-ligament knee reconstruction. This guy, we know, is Rob Leprard, probably the world leader in multi-ligament and sports injuries. And his new approach is early reconstruction. So his paper is on 194 patients looking at early reconstruction in 2 or more ligaments, mostly just 2 ligaments, so ACL, MCL, or ACL, PLC, right? So he's looking at mostly 2 ligaments. And his results with 2 ligaments with early reconstruction are good. But is that something that should guide the rest of us in what we're doing? I don't think so, and I'll come on to that again. So the general rule for me, as I mentioned, is acute repair of the collaterals and delayed reconstruction of the ACL, PCL, which is a staged approach. Now, if you look at there's not a lot of evidence out there, and I'll go through more of it shortly, but 2 main systematic reviews by Jing and Mook both showed that staged reconstruction has 79 and 78% excellent or good results versus 50-ish for acute. Okay, so if you've got an MCL, avulsion of the femur, the best way to treat that is with the repair. That's the most anatomical way of doing it. If you've got a mid-substance tear of the MCL, you're not going to be able to repair that, so I don't advocate you do that. What about the lateral collateral? Again, if it's come off its origin, put it back where it came off from and you stand to do well. What about fibular head avulsions? You're not going to be able to do this all in one stage, okay? This has to be a stage procedure where you repair the fibular head. That's where all the structures are attached to. So your best bet to get a stable knee is by doing a staged operation where you repair this and come back and do the intra-articular ligaments. So with early repair and collaterals, there's evidence, lots of it. Richter et al. 99, repair in less than 1 week gives significantly good results. Less than 6 weeks is still acceptable. More than 6 weeks, things are scarring, things are retracting, there's granulation happening, so you can't do it. And with modern repair techniques, with modern sutures, internal bracing, anchors, onlays, the options are really good to be able to do early repairs very well. What about this situation? You've got a vascular injury, do a posterior approach to the knee. So this patient had a vascular bypass, and at the same time, his postlateral corner was repaired. Okay, so this was a staged approach. The true advantages of doing it staged is you can try to restore true anatomical relationships with the early repair. And with early repair, a third of patients, and the literature shows this, may not need a secondary delayed reconstruction. So just get one third get just one operation. And with delayed reconstruction, there's time for healing of the collaterals and a lower risk of arthrofibrosis. So this is all very important. The disadvantages of a staged approach, there's more than one operation, and the rehab is prolonged because you're going to have 2 operations and 2 recoveries. The comparison is very difficult, as I've already said. A lot of studies are trying to compare situations where the PCL is repaired and the ACL is reconstructed in a delayed fashion, so you can't really do a direct comparison. So I would say consider your patient population. If you're dealing with high energy trauma, knee dislocations, you should do a staged approach. If you've got high level sports injuries, 2 ligaments, then you can think about the early reconstruction. But a tailored approach is necessary. One approach doesn't fit everybody. So in a single stage, you're doing one operation. What are you doing? An early repair, a delayed reconstruction, or an early reconstruction? So that's not quite clear. What are the issues? The length of surgery, if you're going way over 3 hours trying to reconstruct 3 ligaments, that's quite a difficult thing to do. The complexity and skill level is high. And as we've alluded to all day today, graft availability, and there are no allografts available here, and the costs associated to that, and obviously tunnel convergence is a big thing. This is just a quick diagram of the anatomic reconstructions, which is what we're talking about. So if you're going to do an ACL, MCL, PCL, you're looking at a lot of graft, okay, and a lot of complex surgery. Using lots of allograft, which we can't do here, comes with its own issues in terms of cost, disease transmission, etc., etc. Just final bit on tunnel convergence. This is a real issue. Okay, if you're just doing ACL, PCL, you're probably fine. But if you're doing ACL, PCL plus 1 or 2 collaterals, then there's not a lot of space on either condyle to be able to do that. And so these are serious considerations when it comes to it. Now this was that Leprard paper, okay? And so my main criticism of that, using it as a benchmark to do single stage multi-ligament reconstruction, is that these were not knee dislocations. They're usually 2 ligament sports injuries. They're high-level, very motivated athletes. They've got a world-leading setup. They've got loads of graft availability, loads of support, loads of research, and loads of rehab, which the rest of us don't have, okay? So that's a very unique situation. Look at the evidence, right? Look at that column. It's all level 4 evidence, okay? It's all low numbers and low-level evidence. So you can't say, based on any of those papers, what the right thing to do is. It gives a guidance, but it's not gospel. This is one of the review articles, and this is in favor of a staged approach. Here's another review article, again, favored the staged approach, and there's some more evidence to back up what I've been saying. And finally, this was a good little diagram by Sheepers in 2021, which really gives you good guidance of how to approach this kind of thing. So look at your skill setting and patient factors, look at the neurovascularity, look at the soft tissues, look at the bones, and then look at the ligaments at the end, and that's a good approach to do it. So in conclusion, it's a difficult area. The evidence is not strong, and most likely will never be. And treat each patient individually. The approach that you take will depend on resources and skills, and the staged approach, in my opinion, is the safer and better approach to get good results. Thank you very much.